Hello, my name is Turner Overton. I'm the medical director of the 1917 HIV clinic at the University of Alabama at Birmingham. I'd like to thank the organizers for inviting me to participate in the conference, and particularly thank them for their patience with me as I worked through this COVID pandemic to prepare my slides. It's been really a challenge this year, and I'm delighted to be talking about HIV rather than COVID at this conference. I certainly hope that they'll invite me back, and next time I'll be able to come in person. Today I'm going to focus on cardiovascular comorbidities in the setting of HIV. Here's a brief outline of the things I'm going to talk about. First, I'm going to focus a little on the changing HIV epidemiology that we're all aware of. Pivot briefly to talk about obesity and its complications and potentially its role in cardiovascular disease, and then talk about how cardiovascular disease is unique in the setting of HIV and what we need to do to prevent these complications. Here's some data from the Kaiser Permanente group that really focuses on the increasing life expectancy of people living with HIV. And here they have about 39,000 individuals in the Kaiser Permanente group, and they match them 1 to 10 with people who are uninfected with HIV to look at the change in life expectancy for people over the last 20 years of the HIV epidemic. And if you look at the top, you can see that for people without HIV in the blue, life expectancy has been relatively stable over the last 20 years. Whereas people with HIV, we've seen a striking increase in life expectancy, where people with HIV now are approaching the same life expectancy of people with HIV. There's a clear narrowing of the survival gap. Now it's only 9 years shorter for people with HIV than those without HIV. And while that is still a gap, it really shows the striking increases that have occurred over the last 20 years. Unfortunately, what we see as well is that a period without any comorbidities, particularly cancer, diabetes, cardiovascular disease, liver disease, kidney disease, or lung disease, remains much shorter with those living with HIV, such that in 2000, it was only 10 years till someone with HIV was expected to have another comorbidity versus nearly 30 years in people without. And this disparity has remained over this last 20 years and really speaks to a challenge that we have among our patients. Now, one other piece of data that came out of this analysis was even people with a CD4 count greater than 500 at time of entry into HIV care have a reduced life expectancy when compared to HIV uninfected people. So we still have challenges that we need to meet. This isn't the first study to really highlight this disparity in terms of comorbidity. Here's data from a Danish cohort where they had both HIV and HIV uninfected people. And if you look at the table on the left, or the figure on the left, you can see that for just about every comorbidity that they evaluated, numerically there were a greater proportion of people with HIV than without HIV who had these. And a number had a significantly increased risk: hypertension, cardiovascular disease, peripheral artery disease, and chronic kidney disease, all of which clearly have a vascular component to them. And when you look at the table on the right, or the figure on the right, you can see that for any age group, you can see a greater number of multimorbidity, 2 or more comorbidities in an individual, which really suggests a challenge for us as our patients age. Not only are they going to have to address their HIV and remain adherent to their HIV medications, but there's also significant polypharmacy related to these other comorbidities. And so we can actually say that HIV appears to accelerate the prevalence of multimorbidity among people living with HIV. Now, why do we see this? A big thing that we see is weight gain with the initiation of antiretroviral therapy. Early on, we recognized that with the initiation of ART, people regained weight, and we initially stated that this was a restitution or a return to health phenomenon. But I think we're recognizing more and more now that this doesn't truly represent a restoration of health, but maybe an alteration of health and wellness. Here in this study, Grace McComsey and others looked at the changes in body composition in individuals who initiated antiretroviral therapy with either one of the boosted protease inhibitors or with the integrase inhibitor. And what you can see here is that for all three of these, there was a striking increase in adiposity, both in terms of visceral adiposity tissue here on the left, or subcutaneous adipose tissue, and a striking 4 to 5% increase in BMI over a 96-week period. And there was no difference seen between the protease inhibitor-based therapy or the integrase-based therapy. And I think these data have been borne out, and alarmingly so, in the ADVANCE study that has been presented over the last couple of years, where we see a striking gain in weight in both men and women who are initiating our first-line therapies now, with a disproportionate increase in those who initiate dolutegravir plus TAF, with women gaining on average 8 kilograms at 96 weeks. I don't want to spend a whole lot of time going over this study, except to say this is a phenomenon I think many of us are recognizing, is that our patients are starting antiretroviral therapy. They're gaining significant weight, and much of this weight is adipose tissue, and it's being deposited in ectopic locations where it can cause significantly worse disease. So what are some of those consequences that we see? Here's some data that came out from the VA cohort that looked specifically at diabetes, and here they compared people with HIV to HIV uninfected individuals. And what they saw is when people entered care in their system, people with HIV had a lower BMI, 25 versus 28, but they had a striking increase in weight gain with an average of 4.3 versus 1 pound per year in terms of weight gain. Now, furthermore, as these individuals gained weight, what was the effect on diabetes? We know that there's a clear correlation between weight gain and incident diabetes, but there was a striking greater increase as people gained weight if they had HIV, really suggesting that there was some additive effect of HIV to the development of diabetes. So an increased diabetes incidence for every pound of weight gain in the setting of HIV. Furthermore, we know as well that obesity can increase the risk of neurocognitive decline. Here's data from the ACTG A5322 study, where they're following older HIV patients longitudinally, and what they see here is that clearly age was associated with an increased development of neurocognitive impairment, as were overweight and obese individuals. So clearly obesity can affect our brain function and our cognition, some of which may be driven by effects on the vasculature to the brain. A third organ that I just want to highlight briefly is the effect of ectopic adipose tissue in the heart, or epicardial adipose tissue. We often don't think about this because we can't see it, but we know that this is a depot for ectopic adipose tissue that's similar to visceral adipose tissue, and it really has some pernicious negative consequences for people who develop significant epicardial fat. Furthermore, we know that this is increased in the setting of HIV. This has been shown by Janet Lowe, even matched for age, race, and BMI. And this significantly contributes to the development of atherogenesis, both by attracting macrophages, which are activated and can form plaques, and also by generating cytokine production, which increases the inflammation in the heart and in the coronary arteries. Finally, not only can this lead to atherosclerosis, but it also can lead to cardiac fibrosis and progress to heart failure, which is one issue that we're seeing a lot more with our patients. So we also need to recognize that this ectopic fat, is being deposited not only in tissues that may be normal or healthy, but also in a number of places where it is unhealthy and can contribute to disease, including in the heart, which can lead to cardiovascular disease. One final item that I wanted to talk about before we transition to focus on cardiovascular disease is physical inactivity and the link to obesity and comorbidity. I work with Amanda Willig, a nutritionist in our clinic who also is a researcher, and using the Phoenix cohort across the U.S. CFARS, what she has shown is that physical activity is extremely common and linked to a number of things. Now, first and foremost, it's linked to obesity, and I've already mentioned that. Overall, in this cohort, 35% have obesity, but depending on the level of physical activity, the lower the physical activity has the highest rates of obesity in this cohort. And furthermore, when we look at other comorbidities, and particularly here I'm looking at hypertension and cardiovascular disease, you can see a striking, significant increase in these comorbidities in people who have low physical activity and obesity. And furthermore, it's also linked to multimorbidity, which can complicate the care of our patients, as I mentioned earlier, for the management of polypharmacy as well as multimorbidity. So if we pivot now, I think that you recognize that our patients are living longer, but challenged with the face of a growing number of comorbidities and multimorbidity. Let's focus in on cardiovascular disease in the setting of HIV. Virginia Triant at Harvard was one of the first investigators to highlight that cardiovascular disease and here myocardial infarction rates are higher among people living with HIV than when compared with HIV-negative individuals. What you can see here in this graphic is that there is a 1.75 increased relative risk for people with HIV to have a myocardial infarction compared to people without HIV. And when you look at this graph here on the right, you can see there's a striking increase in the risk as you go up in age rate, really suggesting that this is not just an additive effect of HIV, but the longer a person has HIV, it's a synergistic greater negative impact, really suggesting that something underlying is ongoing that's driving this process beyond just traditional risk factors. Similarly, Matt Feinstein from the NA Accord group has shown that over the last 15 to 20 years, we've seen a striking increase in mortality rate related to cardiovascular disease for people living with HIV. You can see here for both men and women, a more than doubling effect of cardiovascular disease in the setting of HIV. Finally, Matt Freiberg used the VA cohort to look again at the role of HIV in the development of myocardial infarction. And what you can see once again is the incident rate ratio for acute myocardial infarction is pretty stable, from 1.3 to 2.2 increased incident rate ratio for the setting of HIV. And in their adjusted models, when they looked for other recognized risk factors, what they saw was the impact of HIV was comparable to traditional risk factors such as hypertension, diabetes, and hyperlipidemia, really highlighting the fact that HIV is an independent risk factor for cardiovascular disease. One final study that I really like, because I think it really brings home where we are in terms of the HIV epidemic and thinking about cardiovascular disease, as well as other non-AIDS related comorbidities, is this study from the New York Department of Health, and here led by Dr. Hanna, where she looked at the changing epidemiology of mortality for people living with HIV. What you can see in the blue at the top is a striking decline in HIV mortality over this period from 2000 to 2012, and a marked increase in mortality related to cancers and cardiovascular disease. And specifically, when they looked at cardiovascular disease, what they saw was there was a notable increase in cardiovascular disease mortality among people with HIV, an increase from 7% of deaths to 13% of deaths, while there was a decrease in the general population. And the adjusted hazard ratio was 1.54, really suggesting a 54% increased mortality for cardiovascular disease among people with HIV compared to HIV-negative individuals, even after adjusting for age, sex, race, ethnicity, location, and year. So once again, an increased relative risk compared to the general population, which is really significant. Now, when we look at the population specifically, and this is one of the reasons I really like this study, they looked to see what was the effect of viral suppression. And what you can see is that for individuals who remained virologically suppressed throughout this follow-up, the rate was half of what it was for individuals who had even one elevated viral load. 3.9 cases of cardiovascular mortality versus 7.7 per 1,000 patient years. But what was notable was this remained higher than the background rate in the general population, even for those with fully suppressed HIV, really indicating that we have a challenge to face, and we need to understand what the factors are that are driving excess cardiovascular disease and cardiovascular disease mortality among our patient population. So why is this? I think one of the key reasons is the underlying chronic low-grade inflammation that we see with HIV. Here's some data from Kevin Yarashevsky, where he did FDG PET imaging of the coronary arteries in people with HIV and matched that to people with HIV. In this study, all the people living with HIV were fully suppressed. And what you can see here, this is the coronary arteries here and here and here. And we looked at many different factors, but this FDG PET imaging allows us to look for metabolically active plaques that are the ones that are more likely to rupture. And they generate these what are called low attenuation plaques that you can see here. And so these are full of oxidized LDL particles and activated macrophages, which become foam cells, which can rupture and form and cause an acute myocardial infarction. So you can see these here as well as here. And so HIV patients had increased low attenuation plaques as well as positively remodeled plaques and increased body calcification. And all of this is related to vascular inflammation with increased metabolically active macrophages and greater non-calcified metabolically active rupture-prone plaques. So once again, these data highlight that there's excess vascular inflammation in the setting of HIV. Now we show this with Dr. Yarashevsky, and it's also been illustrated by Dr. Markelazani at Harvard. So what we know is that atherosclerosis is an inflammatory process where you have endothelial smooth muscle disruption and then the activation and infiltration of macrophages, oxidized lipid accumulation, and the formulation of these lipid-rich plaques that are easy to rupture and cause a myocardial infarction. In the setting of HIV with greater vascular inflammation, we have even more metabolically active macrophages and greater non-calcified metabolically active rupture-prone plaque. And so we know that the vascular inflammation associated with HIV is contributing at least to some degree to the acceleration of the formation of these plaques. And this leads us to the inflammation hypothesis. So this really is not novel to HIV. It's in any disease process. So when we are faced as an organism with a pathogenic stimuli, we have a strategic inflammatory response that occurs driven by interleukins, TNF, TGF-beta, and these are created to clear whatever that pathogenic stimulus is and then return us to some normal state. Now, unfortunately, in some settings, the stimulus can persist, and this leads to a pathogenic response with an ongoing inflammation leading to fibrosis, tissue destruction, altered function, and progressive disease. And this is exactly what we see in HIV, where we have chronic, even with the treatment and control of HIV, we still have ongoing antigenemia that can drive this inflammatory process and lead to end organ disease. And here we're talking about cardiovascular disease. So if we think about the why we have excess cardiovascular disease among people living with HIV, first and foremost, HIV, like most chronic viral infection, induces this persistent low-level inflammation, causes these altered T-cell and monocyte populations, and increased circulating oxidized LDL particles, and increased vascular inflammation, all of which accelerate the formation of atherosclerosis. This persistent inflammation facilitates the development of rupture-prone atherosclerotic plaques. Now, furthermore, we have to remember that for many of our HIV patients, certain traditional risk factors are also enhanced that may be contributing to this disease process. Here's some data from Carrie Alpha from the NA Accord group, where she looked at nearly 30,000 people with HIV and 347 adjudicated myocardial infarctions. And what you can see is that traditional fixed risk factors plays a significant role in the development of myocardial infarction for these individuals. So we still need to really think about those. Now you can see also advanced HIV disease as well as poorly controlled HIV also contributed. But we can't forget about cholesterol, hypertension, smoking, and other traditional risk factors when we're thinking about treating our patients to prevent myocardial infarction. So we think about non-AIDS comorbidities and specifically cardiovascular disease. There are clearly traditional risk factors that we can address, some of which we can't address like host genetics, but diet, lifestyle, and substance use and tobacco use, which may be increased among our patients, are items that we can address. Furthermore, we know that HIV infection and antiretroviral therapy likely increase. So if we can suppress HIV viremia and try to mitigate some of these effects, we can play a big role. There's still a number of questions for the future. What's the role of HIV, the role of antiretroviral therapy, particularly the weight gain with antiretroviral therapy? Are the effects reversible? Is early treatment key? Is management different among people with HIV? So statins are an interesting class of drugs that are known to reverse atherosclerosis. Here are two studies in the setting of HIV, one by Janet Lowe and one by Grace McComsey, looking at two different statin therapies, atorvastatin and rosuvastatin, both of which were shown to reverse atherosclerosis. Here's some imaging you can see from Janet Lowe's atorvastatin study, and this is actually a placebo patient who at baseline and at month 12 you see an increase in this low attenuation plaque. And when we looked at the population, she saw actually a regression with atorvastatin that was beyond what would be expected with just LDL lowering, really suggesting there's some anti-inflammatory effects here. Similarly, Dr. McComsky with her rosuvastatin study showed a stabilization of CIMT, carotid intima media thickness, and showed that this was mediated by a number of inflammatory markers, including monocyte activation markers, really suggesting that this plays a key role in prevention of progression. Now, unfortunately, when we think about statins, and here I'm also going to talk about aspirin, we as HIV providers fail often to optimize these preventive therapies. Dr. Greer Burkholder from my clinic in UAB has looked at this very issue and showed that for people with HIV, only 44% of persons with elevated LDL are reaching their cholesterol goals, and only 1 in 5 are receiving an aspirin as primary cardiovascular disease prevention. And if we look at who achieves good reduction with lipid lowering therapy with statin use, only about a third of people achieve 30% reduction after an MI, and only 1 in 5 has 50% reduction in LDL after an MI, really suggesting while we may actually start a statin, we may fail to optimize that therapy for our patients. So we have some clinical inertia to overcome, and one of that may be because we have inadequate data. We know that people with HIV are at increased risk for cardiovascular disease. We don't know to what degree statins can prevent cardiovascular disease and should be recommended for primary prevention. Though well tolerated in small studies, there's no data from large randomized clinical control trials to really inform this. And then questions of how statins will uniquely work in HIV, particularly thinking about this inflammatory component that is driving atherosclerosis. So the REPRIEVE study was developed for just this reason, and I'm delighted to be an investigator on this with the PI Steve Grinspoon and Pam Douglas, in which we've enrolled over 7,700 patients to be randomized to either pitavastatin or placebo as primary prevention in HIV patients with low to moderate risk for HIV, including in this study is 800 patients who are involved in a mechanistic sub-study that's really going to get to the underpinnings of what is happening with statin therapy. Furthermore, this is going to answer questions not just about coronary artery disease or cardiovascular disease, but also many other endpoints, including inflammatory, immunologic, and metabolic biomarkers, as well as on other AIDS comorbidities like diabetes, infections, and cancer. And furthermore, we have nearly 1,000 individuals from Thailand who are enrolled in the study. here are the hypotheses of the study. We're really excited to have both a clinical trial but also have a mechanistic sub-study. We can look at the reasons driving, the underpinnings driving atherosclerosis and HIV. Now, when we think about HIV, really, obviously, suppression of HIV is the first thing that we have to think about, not just from an HIV disease standpoint, but for many of these comorbidities. But then we move beyond that. There are many items that we need to be addressing with our patients: smoking cessation, key lifestyle factors, lipid-lowering therapies, and addressing other traditional risk factors like hypertension and diabetes. I often think about it as the ABCDEs of cardiovascular disease management. A for Aspen, B, blood pressure, cholesterol, diabetes, exercise, and smoking. We know that if we don't address these issues, then our patients are going to be affected detrimentally by diseases such as cardiovascular disease. So in summary, HIV and its therapy have the potential to contribute to cardiac risk along with the traditional host factors. We know that controlling viral replication partially reduces cardiovascular risk, but our patients still have excess risk. Early antiretroviral therapy may significantly mitigate the HIV-associated cardiovascular risk by limiting the amount of inflammation. We don't have reliable inflammatory markers to predict risk among our patients, and unfortunately, the currently available risk scores fail to accurately estimate cardiovascular risk among our patients with HIV. However, we know that smoking cessation, dietary, and exercise interventions are effective in the setting of HIV and should be aggressively pursued for our patients. Statins may be of benefit in addition to lipid-lowering effects, thinking about the anti-inflammatory effects. However, we need more data to inform this, and Reprieve will hopefully serve this process. I want to thank once again the coordinators of the conference for inviting me to participate, and once again, I hope next time to be able to participate in person. Everybody stay well. Bye-bye.